still have 3 speakers left and a keynote address. So without further ado, we're really looking forward to this talk on topoguided treatment in difficult situations by none other than Dr. Rohit Shetty.
Thank you, Shreyas and Gitansha, for this opportunity. And I'm going to speak on topoguided treatment in difficult situations. Divided it into two talks, two components. One is for keratoconus and non-keratoconus. So I will, in the interest of time, for 8 minutes, there are different machines we can do these treatments, but I will stick to Schwinn-Amaris platform so that we can discuss more cases. No financial interest in this. Basically, when you look at basics of wavefront imaging, you can look at what is on the cornea, and this is a treatment plan. It basically takes care of the irregularity. But if you're looking at ocular wavefront, it looks at the corneal and also how the lens, in this case, trying to negate the effect of the whole eye and trying to see how it can correct. Basically, when you look at these two images, it's of a same patient, graphically represented, but the lens accommodates or tries to reduce a lot of aberrations. So you can see the map is exactly of the same patient, more ablations and less ablations. So in one word, the corneal wavefront versus ocular wavefront does seem to reduce the amount of aberration. The question is it good or bad? It depends on each patient, because reducing the ablation doesn't mean that it's actually correcting this area better. If there's an increased aberration, it does not always mean that your cornea is getting regularized. So this is always a big challenge in understanding of these, making the cornea regular. And these are the techniques, both from the Osiris and like I said, if you're using Alcon, you only have the topolizer, and Bausch also gives you the total abrometry, but it's a Hartmann shack. Very difficult to get a good reliable readings. In this case, these abrometers are pyramidal based systems which are able to get much better readings and more repeatable. So this is what happens when you look at the treatment planning. And the advantage here is that you can compare the profiles of a same patient. If you are looking at the profile, the CW is the corneal, the OW is your ocular wavefront. So when you're looking at any of the laser-based treatments, at one screen you compare, and these new software gives you the ability to pick and choose what aberration you don't need. If you don't want to spend so much of time, you can ask the machine to choose what is the main culprit and ignore what is not. So ultimately, you get a treatment plan which may be completely different, because this is based on what the lens is compensating, and this is based on what the cornea is. If you're looking at a topolizer, you'll probably be doing this. If you're using a Schwinn, probably you look at these two things and you can see, okay, you can see the ablation pattern reduces by half or even more. So virtually, your ability to reach out to patients, more number of patients increases when you are actually comparing these two. The traditionally topoguided treatment is more on the cornea, but when you increase your range to ocular wavefront with the modern day technologies, then you can actually look at more number of patients being treated. This is again a comparison, and you can see that the ablation depth, and you can see that this is the same patient with much better depth, with minimizing. It's called the minimizing effect, and it creates the changes out here. So why is that minimization effect is? It does not treat. Many times we have to understand the cornea also has a lens in our optical system which kind of regularizes a lot of aberration happening. But when you do a topoguided treatment, say with any of the Alcon platforms, it completely ignores the effect of lens. It only looks at cornea only, which is not a true optical system. The optical system is made of lens and other things, and including the neural factors, which dampens the noise till it reaches the cortex. So this is why it is important that you have to look at both these factors. And when you look at a lot of these patients, you can look at this. If you're just doing corneal wavefront treatment, this machine would correct around 5.5 diopters of coma. It would correct around 0.2 of trefoil and 2 diopters of spherical aberration. This, if you had to correct this, the cornea would burn around 90 microns in the periphery and 24 microns. But when you use an ocular wavefront guided treatment, your ablation drastically drops to 9 microns because the coma has become 1 diopter. That means 4 diopters of coma is completely negated by the lenses. This is a young patient. What happens when he becomes 40, we don't know, because maybe new abrasions will come. But at this point of time, the machine says that 1 diopters of spherical aberration is negated and 4 diopters of spherical coma is negated by the lens itself. The accommodation, the way how the lens takes care is phenomenally good, and you reduce it by 90%. So this is the power of what a total wavefront guided treatment is. And when you start doing, you get these kind of images, and these are again a comparative things which I'll not go. And when you correct it, you can probably get these kind of images out here, which is very important. But there are cases where you use both, the ablation pattern is very high. And we published this work. This was also a winner, one of the best videos last year. When you look at just doing a small PTK, you can customize. It's called Trek. This is in JRS 2-3 months back. I think it's online. And you can do a long axis, short axis from the topography. And then when you do this ablation pattern with all cross-linking will give you these kind of results. And now we have close to 5 years of follow-up of these patients, and none of them have actually gone for progression. There are other reasons why you need to do it. One is before cataract, if you want to do a zone enlargement. Again, using this is a place where you don't do a ocular wavefront because the lens is already cataractous. So you can just do a topo-guided treatments and then probably do a cataract. Post-LASIK scarring, and this again was published, where this was a patient referred to us with the scar. And we do a lot of these things. You can customize the scar according to where the place is. And you can see that when you do a PTK on that zone only, it's more like this is what we publish first and use the same principle onto this. And you can do a long and short axis PTK exactly on that zone. So it doesn't really affect the refractive status. And this is the video from there. Just that PTK is just like a coffin placed inside. It doesn't affect any other part of the cornea. It is cyclotorsion compensated so that you don't have to worry that the laser will fire beyond the scarred zone. And then this is the quality of image, post-op OCT. And we do a lot of these things now. And sometimes we use it for PTK also, exactly recurrent erosion syndrome, where you feel that you don't want to create any changes to the refractive error. It's a phenomenal use of modern machines, especially machines which allow you to do all these changes, completely changes the way you do a customized laser surgery. We know all these factors here, and how does it help is we call the scar Trek. The Trek is topo-guided removal of epithelium. It's more like a PTK, but we use 10 microns more so that it just shaves off those cornea. Little more sophisticated way of Cretan protocol. And thank you again.
Thank you so much, sir, for the very enlightening talk. And while I request Dr. Praveen Krishna to kindly set up his laptop, sir, challenge has always been, from the days of original wavefront guided treatments, that the measurements are very dynamic, and it's difficult to really have say that the measurements that we are getting and treating based on wavefront can be accurate. How has it changed now in terms of the newer ways of measuring them with the Cirrus and the newer scans available? Why do you feel these are more reliable today?
The machines are more repeatable, the abrometries are more repeatable, and at the end of it, you're not really looking at a complete refractive error correction, you're more regularizing it. So most of the time we correct only the regularization part of it. Me and Garrick have looked at our 12 years data of patients who had follow-ups. We got around close to 700 patients who followed up. We could get them on a regular follow for 12 years. Of the 12 years people who had done a laser-based cross-linking, the number of people who had recurrence of regression were less in a topo-guided treatment compared to the one where we had done a conventional cross-linking. So that means scar has some way of protecting it, and 90-94% of them did not need contact lenses. They be more of a spectacle independence, which shows that the quality of vision. So 12 years is a long data to prove, and he's just writing this up as a paper. So I'm fully convinced using one of these technologies, I'm more than 99% using one or the other laser forms to correct my keratoconus. Just cross-linking, I just stopped.
Interesting, Rohit. I mean, you all started with wavefront with optics, went to topoguided, going back to wavefront. But in some of these
Challenge was always not the lasers, sir. The challenge was the machine.
getting that.
Yeah.
So some of these irregular corneas with corneal scars, etc., getting a reliable wavefront map itself should be
The
very much of a
pyramidal
challenge.
system gives you around 95% of them. 95% of them we are able to, even with highly irregular corneas you get with this, and we do 3-4 readings of it. And if all readings are matching, only then we plan for the procedure. The newer abrometries are more smarter than what we started with, sir. Even today, if you go back to use your Bauschen LOM, it still says image acquisition failed.
What is the lowest fraction? Most of these patients also have.
That's what I said, ma'am. If you're looking at one of the Trek-based techniques where you're using the epithelium plus around 10 microns, with the new thin cornea calculators, I've gone up to 330, 340, and we have 4 years follow-ups of them.
Do you get any scars in these patients?
Very minimal. The reason we don't get scars in very thin corneas is because their keratocytes population is 60% less than the scar happens with keratocytes when become myofibroblasts. That's why you get more in thicker corneas, more healthier corneas because they are more healthy.